to the stage Philip Pibero. Uh, Philip is not new to us. He has been visiting us and collaborating with us, and we have been amazed by his extensive work in the field of valvular heart disease. He's obtained his doctorate at the University of Claude Bernard in Lyon, France, and subsequently he's now the full professor at the Department of Medicine at Laval University. He is the head of cardiology research and director of echocardiography core laboratory at Quebec Heart and Lung Institute, and he's the editor-in-chief of the Journal of Heart Valve Society. His work, which includes over 850 articles, over 1,500 invited presentation, and publications that have been cited over 100,000 times, with an outstanding H index of 141, being 1% most influential scientist in clinical medicine every year since 2018. He's ranked number 2 overall and number 1 for the last 6 years among all the scientists at University of Laval. He has won numerous prestigious awards, including Research Achievement Award from the Canadian Cardiovascular Society, Feigenbaum Lecture Award from the American Society of Echo, and the Doctorate Honoris Causa of University of Liège, Belgium, and Distinguished Lecturer Award from the Cardiovascular Sciences in 2022. He has been collaborating with us in valvular heart disease very closely. We have been working on several new models using AI and innovation. And today for us, he is going to talk again about his key area of aortic stenosis, where he has made some pivotal contributions, specifically with the whole timing of intervention moving towards asymptomatic valvular stenosis. I think the time is opportune for us to hear from a stalwart like him. With that note, I bring in Philip Pibero to you all. Philip, the stage is yours.
Thank you so much, Pato, for this very kind introduction. I hope that you hear me well and see well my slides.
Yes.
It's always a pleasure to present at Rutgers because I have close collaborators there. We are now collaborating for a long time with Pato, and had very fruitful collaboration and great research adventure, published several very interesting paper. And I have many friends as well. So it's always a pleasure and privilege to present to you. These are my disclosure that I want to make sure you see first, because it's especially we are the echo core lab for several major trials in the field of TAVR, and in particular some are related to the timing of intervention. So in the progression of aortic stenosis, you know that there is the patients who are at risk for AS, so bicuspid valve aortic sclerosis. And then there is the beginning of aortic stenosis where you have mild, moderate AS. For this patient, that's called stage B in the American guidelines, there is no indication for intervention and only follow-up. And then we move to the stage where here we have hemodynamically severe AS, but the patient has no symptoms, no LV dysfunction. So this is the stage C1. And for this category of patient, there is still a dilemma clinically on whether we should do an early AVR now, a valve replacement, or a more clinical surveillance, or what we were calling before watchful waiting. And then, of course, for the patients who have severe AS and symptoms or LV dysfunction defined as an EF less than 50%, there is already class 1 indication for valve replacement. So I won't discuss this case today. And in the context of aortic valve replacement, I would say, timing, as many things you may say, but timing is everything. If you intervene too early in the progression of the disease, you may expose the patient to the unnecessary risk of the intervention in the prosthetic valves. The intervention, surgical or transcatheter, have a substantial risk, of morbidity and mortality. And when you replace a native aortic valve stenosis by a prosthetic valve, to some extent you replace the disease by another disease, and the prosthetic valves are associated with several complications. And then if you intervene too late in the course of the disease, well, the main risk for the patient is irreversible damage to the myocardium. And so the patient may not recover the cardiac damage that has been related to the exposure to the LV pressure overload by the aortic stenosis and will have sequelae of the disease. So I participated to this great debate that was published in European Heart Journal 2 years ago, and interestingly, I was given the contra side. So in the sense that I was defending that not all patients with asymptomatic CVAS need AVR, and David Messi-Cazzetone was defending the pro side. Um, and the pro side, is, I would say, probably easy to defend. That outpatient with asymptomatic CVS should undergo AVR. There is, always a risk, although it's rare, but of sudden death. The risk of, again, that was discussed, irreversible consequences, especially myocardial fibrosis, cardiac damage, you know, at the level of the four chambers, not on the left ventricle, the left atrium, with eventually the LA dilation and LA fibrosis leading to atrial fibrillation, etc. And also, of course, RV dysfunction. That is generally associated with poor prognosis. And also nowadays, we have to say that the operative risk of intervention are substantially decreased, and that now we can do a surgical transcatheter aortic valve replacement with really minimal risk, procedural risk, I mean. And as we'll see, there are several now RCTs, randomized trial, that demonstrate better outcome with early intervention. On the contra side, I think, still, as soon as you do an intervention, there is a risk associated with this intervention, and you're doing this in a patient with asymptomatics who does not complain of anything. So maybe the risk of worsening the patient is, of course, higher. The issue, and that we'll discuss later, is that we have now several RCTs that have generated data about the timing of intervention in this patient. But what about the generalizability of these RCTs? As we'll see, that the randomized trials are not necessarily real life patients, and it might be difficult to generalize. So this is a patient, may go one back. Maybe the video clip is not playing. That's not a problem. This is like a normal LV function. So this is a 78-year-old man with a body surface area of 2.02 meters square, asymptomatic, confirmed by his exercise testing. So it's really, he did a treadmill at good exercise performance. So it's a true asymptomatic, no evidence of cardiovascular risk factor, no evidence of coronary artery disease. He has a preserved EF that we'll see on the next slide is about a bit more than 60%. The stroke volume in the LVOT is 85, so index means 42. So this patient is not in low flow state, and you remember the cut point for low flow is 35 ml per meter square. The peak jet velocity is 4.25 meters per second, mean gradient 46, valve area by continuity equation 0.89, index 0.44. So this is, the typical patient with severe AS, no symptoms, and I'm sure you're seeing this type of patient probably every day. And if we go a little bit further, again, the LVEF is preserved. Diastolic dysfunction grade 1, which is expected for a patient with no symptoms, mild MR, some MAC, and a trace TR, and a normal systolic PAP. Okay, so what are the guidelines? Well, there will be new guidelines later this year, but what do we have for now? This is the 2021 guidelines, and for asymptomatic severe AS, there is no class 1 indication for intervention unless the LVEF is less than 50%, or if there is another indication for cardiac surgery, which is not the case of our patient today, and which is not the case of the vast majority of patients with asymptomatic severe AS. But in the guidelines, there are some openings. I mean, if you have a very severe AS, which is defined as a peak velocity more than 5 meters per second, or a BNP that is markedly elevated, which is threefold above normal, or rapid disease progression. Rapid disease progression in the guidelines is defined as a progression rate of the peak velocity of 0.3 meters per second per year or more. Um, and you have a low surgical risk, then you may consider a surgical valve replacement, and it's a 2A indication in the guidelines. Okay. So the case that we have today, well, as none of the risk marker listed here, the only thing that this patient has is a low surgical risk. So if you look at the guidelines, you would say, well, this is not a patient for early intervention. Okay. So the dilemma, as I said, should we do still early, let's call it prophylactic valve replacement or watchful waiting, which means wait for the onset of symptoms and or LV systolic dysfunction to trigger intervention. So um, since the last time I presented, at the cardiology grand rounds at Rutgers, we've made some progress in terms of randomized trials. We have now the results of 4 randomized trials that are summarized here. So I would say the oldest one is the recovery trial. This trial from Korea was published in New England Journal of Medicine. Small group of patients where they compared early surgical valve intervention versus conservative management. Then there is Avatar. Again, they use SAVR in this case. That has been published, several years ago, an update published last year with longer follow-up. And then there are the 2 major trials that have been published last year. The EVOLVE trial, in which, in this case, the earlier intervention was done through SAVR in 80% of the cases, 20% TAVR. And finally, the early TAVR trial that we'll discuss in more detail because I was involved in this trial, where here we did only TAVR for the earlier intervention. And this is also the largest trial in terms of number of patients with 901 patients. So recovery is a small trial, about 70% patient in each arm. It's not all comers because it only recruited patients with very severe AS. So you needed to have a peak jet velocity more than 5 meters per second to get in this trial. No symptoms. And yeah, I mean, it was published in New England Journal of Medicine in 2019, and you see better outcome, so lower rate of mortality and all-cause mortality, and also cardiovascular mortality with early surgery versus conservative management. So this was the first proof of concept. Then came Avatar. So Avatar, again, a small group, relatively small, about 80 patients in each arm. And here they use as a primary endpoint a MACE, so it's a composite of all-cause mortality, acute myocardial infarction, that is a bit strange here, stroke, heart failure, hospitalization. And again, there was a superiority of early surgery versus conservative management. Last year, they published an update with a longer follow-up showing that there still is, now with about 6 years follow-up, there is still a superiority of earlier intervention for this primary endpoint. So Alain Cribier, as you know, has made a huge contribution to the field of treatment of aortic stenosis with the first balloon valvuloplasty, the first TAVI, and he was a giant in cardiovascular medicine, a pioneer, and also a good friend. And I think he opened the way to this trial for early intervention, because for many years we have tried to get this early AVR trial funded by the NIH and other granting agencies, in asymptomatic patient with severe AS. But it was always difficult because what you propose in a patient who has no symptoms is to do an invasive intervention, which is an open heart surgery. But then when TAVI TAVR came in, well, we had a less invasive option to propose with, almost the same day discharge or next day discharge. So it made this trial easier to, let's say, to sell and to get accepted, both by the granting agencies, the industry, the sponsors, and the patient as well. So this is where we designed the early TAVR trial. And Philippe Généreux, my Canadian fellow, was the PI with Alan Schwartz. So this is a 901 patients randomized. So these patients they need to be older than 65 years old, STS score less than 10%, preserved DF, true asymptomatic, confirmed by exercise testing, and they are randomized to a transfemoral TAVR with the SAPIEN 3, so or SAPIEN 3 Ultra, so balloon expandable valve versus clinical surveillance. The primary endpoint was a composite of all-cause mortality, stroke, or unplanned cardiovascular hospitalization at a follow-up of 2 years. So this is the primary endpoint. We published that last year in the New England Journal of Medicine, and clearly. We passed the primary endpoint. This was the trial was designed on the basis of a superiority hypothesis that was met. There was 51.2% incidence of the primary endpoint in the clinical surveillance arm versus 35.1% in the TAVR arm. So with a number needed to treat of about 6 at 2 years, which is great. Having said that, let's go now more in maybe the other endpoint, the key secondary endpoint. All-cause mortality, there was no difference between the two arms. There is, the two curves are perfectly superimposed. Same for stroke, but stroke was not significant, but I draw your attention that if you look at the numbers at 2 years, there is still some substantial numerical difference and a trend in terms of the p-value of also statistical trend. 9.5% stroke versus 5.4% at 60 months, so at the end of the follow-up. And so at 2 years, again, was not significant, but there is something happening here that grabbed our attention, and that was, I would say, unexpected. So the primary endpoint, as shown on this slide, is essentially driven by this component of the endpoint, which is unplanned cardiovascular hospitalization. And we've been criticized for that because unplanned cardiovascular hospitalization included heart failure, hospitalization, etc. But also the patients who were hospitalized, the patients in the clinical surveillance arm were hospitalized in the next 6 months post-randomization for a conversion to aortic valve replacement. So because we assume that if the patients, was considered at randomization of not requiring valve replacement, if this patient would need valve replacement during the next 6 months, this would be considered as unplanned cardiovascular hospitalization and therefore as a primary endpoint. And you see that most of the difference between the two arms occurs, in the first 6 months, essentially because of this conversion to AVR, hospitalization for conversion to AVR in the clinical surveillance arm. Okay, so now having said that, this is why we also provided this endpoint, this composite, which is maybe more robust, you would say, death, stroke, or hospitalization for heart failure. And still, there is a clear superiority, even if it's clearly smaller than with the primary endpoint, with the early TAVR. Okay. So the other things that I think is in favor of early intervention, the health status outcome was much better in the TAVR arm. So with, the health status was optimal, let's say, in 86.6% of the TAVR patient versus 68 percent of the patient at 2 years. And also, we had a marker of integrated left ventricular and left atrial health. And again, this was so based on echocardiographic parameters. And again, this was significantly better with early TAVR than clinical surveillance. Now, this is a curve that we were calling with Philippe the rainbow curve, and you will understand why. This is in the clinical surveillance arm, this is the signs and symptoms at the time of conversion to AVR. And I draw your attention that, in the clinical surveillance arm, so the patients were initially randomized to clinical surveillance. At 1 year, already 47% of them, so about half, had required a conversion to AVR. And then you see at 2 years, it's 71%. And by 5 years, it's almost 100% who actually required conversion. So everybody had AVR in the end. And you would say, yeah, okay, but was this conversion to AVR not really motivated by symptoms and etc.? Well, you see that the majority of the patient had a conversion to AVR because of advanced signs or symptoms. So they were heavily symptomatic. Another important proportion had progressive sign of symptoms, so more progressive development of dyspnea, etc. Whereas, those with advanced sign of symptoms was more syncope, onset of heart failure, etc. And finally, that was we wanted to be sure, very few had a conversion to AVR with no symptoms. Okay, so no clear indication for intervention, or at least no class 1 indication. Okay, so the EVOL trial is the other important trial that was published at the same time as early TAVR, but in JAMA, actually, and it's a smaller trial, and it was clearly underpowered. So 224 patients were randomized. The difference with early TAVR is that it's not all comer with asymptomatic severe AS. It is a population that is at higher risk, I would say. So the patients were recruited, and to be in the trial, needed to have elevated troponin and evidence of myocardial fibrosis on CMR. And the patients were randomized again, routine care, so clinical surveillance versus early intervention. And again, early intervention, the vast majority of the patient was surgical valve replacement. And the primary outcome was all-cause mortality or unplanned aortic stenosis hospitalization. So similar to some extent with early TAVR, except there is no stroke here. Although you may say, well, if there was a stroke, probably the patient was hospitalized, of course. And this is an important thing I would like to emphasize with Evolve is that you see that the timing to AVR in the early intervention was actually not that early, in the sense that the median time from randomization to performing this early AVR was actually 5 months in the EVOL trial versus 14 days in early TAVR. So in early TAVR, it was really early TAVR. In EVOLVE was not really early AVR. And I think this has been detrimental to the trial, as you will see. So this is an important, and this was essentially related to the healthcare system in the UK. There is, even if the patient was randomized, there are some delays in getting the intervention. So the primary endpoint that you see here actually was not significant. So again, it was all-cause mortality and unplanned hospitalization, and there was not even a trend. This is for all-cause mortality, and this is very similar to what we observed in early TAVR, by the way. No difference. And the unplanned aortic stenosis hospitalization was actually significant and similar to early TAVR in terms of magnitude of difference. So if we summarize the four trials done so far, well, the recovery trial met the primary endpoint with superiority and a higher rate of mortality with surgical valve replacement. Avatar met the primary endpoint, again with a superiority hypothesis and lower rate of mortality with surgical AVR. Evolve did not meet primary endpoint, no difference in mortality, and Early TAVR met the primary endpoint, but there is no difference in mortality. So again, and I won't spend too much time on this because I already discussed that. There is, some important difference in the time to AVR in the patients who were randomized to early AVR. So again, 14 days in early TAVR. So this was really early AVR versus 5 months in Evolved, 55 days in Avatar, so and 23 in recovery. So this is important results I would like to share with you is now published in JACC. With Philippe Généreux, we did a meta-analysis of these four trials, and they're very interesting findings, actually. What we found is that, again, no difference in all-cause mortality, no difference in cardiovascular mortality between early AVR versus clinical surveillance. Numerically, yeah, the results are better with earlier intervention. Where the difference are really unplanned cardiovascular hospitalization, clear superiority of early AVR, heart failure hospitalization, clear superiority of early AVR. This is really where we get the benefit. This is more in the rehospitalization, including heart failure hospitalization, which is still an important and robust endpoint. And um, I would say the important and maybe the most surprising finding was there was a benefit that was significant in the meta-analysis. This trend was present in all four trials, but when we pulled together, there was a superiority of early AVR with regard to lower incidence of stroke. Especially, most of the stroke that were avoided were actually after intervention, in the sense that if you intervene earlier, you have less risk of stroke than if you intervene later at the time of intervention. Maybe because the patient is at more advanced stage of the disease, of the aortic valve and cardiovascular disease in general. And so when you perform the AVR on a more diseased valve, either TAVR or SAVR, you have a risk of stroke that is higher. So that's the good news. So you will say, well, now what the guidelines will do. I don't have any crystal ball, but let's say I will commit myself, and I will say my prediction is that the guidelines, European and American, hopefully they will agree together, will probably give one level B evidence indication for early AVR, TAVR or SAVR, in asymptomatic patient with CVIS. We'll see, because I think, with four trials, three positive, the meta-analysis that bring everything together and show some difference in stroke as well. I think this would be an argument to propose a class one. Having said that, I think there will still be a need to individualize and optimize the timing of intervention in this patient. That would be based more on the extent of cardiac dysfunction, damage, failure, etc. Because the randomized trial, there is always a selection bias, and they do not necessarily reflect, all comers that we see in the clinical settings. And furthermore, I don't think that let's say that tomorrow we decide to intervene on all patients with asymptomatic CVIS, many healthcare systems in several countries will not be able to take it, will not have the bandwidth. Already, there has been some survey conducted in Europe showing that about 1/3 of the patient who have now class one indication for intervention, so patients with symptomatic CVRS actually do not get the valve replacement in the end. So we are not able to cover the needs at the present time. So if we add this tsunami of asymptomatic patients with CVRS, well, we're gonna overwhelm the healthcare system, especially in some countries. I can tell you that in Canada will not be feasible. So to help to identify maybe the patients with asymptomatic CVRS that we should prioritize and consider early intervention, I think first we have to look at the left ventricle, but we have to look beyond the LV ejection fraction, because if we look at the LV ejection fraction in a patient with AS, we may conclude that this is a beautiful day with a beautiful sky, calm blue sea. But if we look at other parameters that are more sensitive to subclinical dysfunction, might be a different story. And remember, LV ejection fraction may fool you. What our eyes see, so the LV ejection fraction, is not necessarily what our heart feels or the heart of our patient feels. And this is a relatively old study now, but it's a multi-center study of data that we had in heart valve clinics, and we found two echo risk marker for poor outcomes in asymptomatic patients with CVRS. The first one is the severity of AS, not surprisingly. And again, if you have big jet velocities in more than 5, so very severe AS, the outcome was poor. So, I mean, this provides further support to this class 2A indication that is already in the guideline. And the second one was the LVEF. But keep in mind that in this study, all patients had preserved the F by study design, because otherwise they would have had an indication for intervention. And still, when we broke down the LV ejection fraction into more than 65%, good outcome. Between 60 and 65%, still good. But when you look less than 60, so between 60 and 50, well, here you see a higher risk of mortality, and not in 5 or 10 years, within the next year. So I think there is an important message here. And another study from the Mayo Clinic that was more all comers with LVEF. So you see less than 50%, it's a no-brainer, very poor outcome. Good. More than 60%, fine. But between 60 and 50, the gray curve, again, you see an outcome that is, really in between the two curve, and definitely suboptimal. So I think this LVEF less than 50% that we have in the guidelines for AS, it's too low. It's not sensitive enough. It lacks sensitivity, and so we should probably raise the cut point of LVEF to define LV dysfunction and eventually trigger intervention. And this is actually what has been adopted in the 2021 edition of the guidelines. In the American guidelines, there was a new indication was a 2B indication if LVEF drops below 60%, not 50 now, 60%. The European guidelines, they use a lower cut point, 55%, but stronger indication 2A. Okay. And if another way to overcome the limitation and the suboptimal sensitivity of LVEF to detect subclinical LV dysfunction is to use the global longitudinal strain that we can measure by speckle tracking. And in this meta-analysis that was conducted by one of my former PhD students, Julien Magne, you see that even in the group of patients who have an LVEF more than 60%, and we'll say, oh, no problem, that's for sure, there is no subclinical dysfunction. Well, still, 1/3 had reduced global longitudinal strain, so less than 15% or 14.7% in this study. And if they have such impaired longitudinal function, well, they had lower survival. So this is important to keep in mind. And the case actually I showed you initially as a global longitudinal strain that is just on the edge, minus 15%. So you see, interesting, because this patient, remember, has 63% LVEF, but the global longitudinal strain is, borderline low, and indicating that we are on the edge, with toward maybe considering early intervention. Another parameter that may be used to individualize, the risk stratification and the timing of intervention is the BNP, and especially the BNP ratio, which is the measured BNP divided by the agent sex corrected upper normal value of BNP. And in this paper that Marianne Clavel, one of my colleagues, did when she was a postdoc, actually a fellow at the Mayo Clinic with Maurice Sarano, she found that as soon as the BNP ratio is higher than 1, you see a progressive and incremental risk in mortality. And this becomes very obvious when you have a BNP ratio more than 3. And by the way, this BNP ratio more than 3 fold compared to normal value, agent sex specific normal value, is now in the guidelines, as a 2 indication for intervention. So the case again, if we come back, we are just below the cut point that we have in the guidelines, 2.84. So clearly, this patient is at higher risk, and this might be, sufficient argument if you put the global non-small strain, the BNP ratio to eventually consider an early intervention. Now, for now, we have only looked at, or focused on the one of the chamber, and we have to remember that the heart has 4 chambers, right? So, and I think, in cardiology, and especially in valvular heart disease medicine, we have to maybe to use a similar approach that is used in oncology, where in oncology, really the risk stratification and therapeutic management is based on a twofold assessment. There is first the grading of the primary tumor. Is it grade 1, 2, 3? And then the assessment of the staging of the extension of the tumor, right? With the stage 0, 1, 2, 3, 4. And this is really with these 2 components that you can really assess, the risk of the patient and what type of treatment we should consider. And I think we should do the same in cardiology and for the assessment of aortic stenosis. Of course, we need to grade the severity of aortic stenosis. This is the first step, and we do that. Well, we pay a lot of attention to that, but we also need to stage the extent of cardiac damage related or associated with the aortic stenosis, because at the end of the day, this is what determines the prognosis of the patient. So with Philippe Généreux, we proposed a classification to stage the extent of cardiac damage. And this was initially applied to the data set of partner trials. And then subsequently with one of my former PhD students, Lionel Taste, we adapted this classification to the context of asymptomatic severe AS. So stage 1 means damage at the level of the left ventricle. So this is defined as there are several criteria. So LV hypertrophy using sex-specific threshold, grade 2 or more diastolic dysfunction, an EF less than 60%, not 50, for the reason I explained before, a global longitudinal strain less than 15 or minus 15. And if you have one of these criteria, you qualify for stage 1. You don't need all of them, okay? Then stage 2, well, we go upstream, It's left atrial mitral valve damage with LA dilation, moderate to severe MR, and or atrial fibrillation, which is the only non-echo parameter that we have in this classification. Stage 3, pulmonary atrial tricuspid valve damage with systolic pulmonary hypertension, or moderate severe TR. And finally, stage 4, damage at the level of the right ventricle, that we know is never good news. So moderate severe RV dysfunction and or moderate or severe low flow state, which is defined as a stroke volume index less than 30 ml per meter square. We put that in the stage 4 because when you start to have moderate or severe low flow state, this is a sign of asymptomatic still, but heart failure and decompensation. So these are the results that we obtain in the patient with asymptomatic severe AS. So we were, and this was a multi-center study, again, putting together the data of several heart valve clinics. So really patient well followed and well assessed for symptoms. And In these patients who are true asymptomatic with severe AS, 61% had advanced cardiac damage stage, so stage 2, 3, or 4. So the absence of symptoms does not necessarily mean absence of cardiac damage. So I think the absence of symptoms is falsely reassuring. And if the patient is really asymptomatic, well, look at the echo, look at the imaging. And if this patient had a cardiac damage stage 2 or even more, 3, 4, that is the black curve, well, the stage 3 and 4 were put together, you see an increased risk of mortality. And again, not in the mid or long term, it's really within the first year or two that you feel this impact of the cardiac damage stage. So coming back to our case again, well, there was some criteria for stage 1. You see LV hypertrophy. There was also the global North strain that was borderline, but if let's say that we put it positive, it will not change because it's still a criteria for stage 1. So this patient would be considered to have cardiac damage stage 1. Okay, so according to the curve I just showed you, this would mean that, well, it is reasonable to follow the patient and not necessarily intervene now, based just on the cardiac damage staging, okay? But I think, again, we have to be really multi-parametric, multi-approach to, again, identify the patients who are at risk. This is, again, about cardiac damage, but more the reversibility of cardiac damage. We did this study in the partner trial. So keep in mind that with all patients with symptomatic severe AS here to start with, who are treated by transcatheter or surgical AVR. And I mean, the results have been a cold shower for us. I mean, for Philippe and I, Philippe Généreux and I, because we realized that only 15.6% of the patient showed an improvement of cardiac damage from baseline to 1 year post AVR. Most of them, 57.9%, was statu quo, no change at all. And even a 26.5% had a worsening of the stage. And if they had a worsening, well, this was associated with increased risk of subsequent mortality with a adjusted hazard ratio of 2.25. And what we found is that the predictor of worsening in cardiac damage, which is the worst case scenario, was hypertension. So I think this is important take-home message is that when we treat AS by a fancy, TAVR or SAVR, and we considered the operation had been successful, well, keep in mind that we also need to treat aggressively the comorbidities and hypertension and diabetes and cardiac amyloidosis, etc. Otherwise, the aortic valve replacement TAVR or SAVR may be futile. The other parameter that came out was surgical AVR versus transcatheter AVR. So meaning that many of the worsening of the cardiac damage stage were related to new onset of RV dysfunction associated with open heart surgery. So I think this is an important message. And if we summarize I would say the clinical implementation of this concept of cardiac damage staging in practice is, in the asymptomatic severe AS, which is the topic of today, if you have a cardiac damage stage 0, 1, I think it is reasonable to do a clinical surveillance, but active clinical surveillance, whether follow-up every 6 months or even every 3 months. But if the stage is 2 or more, I think this is an argument to consider earlier intervention. And I think this is ready for implementation in the guidelines. In the at-risk moderate AS that I won't have time to discuss today because I think, we started late and I don't want maybe to go for too long, and save time for discussion. But we could apply the same concept because, as you probably know, there are some randomized trials that are now ongoing to eventually test the timing of intervention, so early intervention versus conservative management, but in at-risk moderate AS. And in the symptomatic patient with severe AS, well, here there is an indication for intervention. But you can use the cardiac damage staging in this patient to select the type of EVR that may be optimal for the patient. And if definitely if you have a stage 3 or 4, meaning a damage of the right side unit of the heart, this is an argument for considering TAVR rather than SAVR because the right ventricle doesn't like the surgery. And I will end with showing you this. This is a study that we did with, I think it's the first study we did with the group of Parto in collaboration. And this was a machine learning framework to identify distinct phenotype of AS severity because now you can use also AI to help you to re-stratify, to enhance re-stratification and identify the patients who are at risk of poor outcomes if they are left on conservative management. And so the patient will need to be considered for earlier intervention. And using actually 5 echo parameters, we've been able to create a score that predict the risk of poor outcomes. So, and we made available this calculator, online, so you can find it at this link. And I just tested the patient that I just showed you. So this patient that I discussed with you today had an index valve area of 0.44, an index stroke volume, so this is index of 42, the peak jet velocity of 4.25, a mean gradient of 46, LV ejection fraction of 63%. And you would say, when you look at this, you say, oh, this is probably not very high risk, but when you submit to the calculator, the calculator tells you, yeah, this is high risk patient with a very high probability. So another argument may be to consider early intervention. So in conclusion, well, for these patients and the timing of intervention in asymptomatic severe AS, there is not yet a class 1 indication for AVR in patients with asymptomatic severe AS, unless EF is reduced or indication for another cardiac surgery. There are several class 2A though for AVR, a very severe AS, fast progression, BNP also that is more than threefold, LVEF less than 55 or 60% depending on the guidelines. And on the results of on the basis of the recent trials and meta-analysis that have been done, because I showed you one, but there are others that have been done and are in press. We'll see what the 2025 edition will do. I would predict it's going to be a 1B indication for early VR in patients with asymptomatic CVS. But still, I think even if it's a strong indication, there will still be a need to individualize, optimize the timing of intervention in this patient. And we have now several things we can use. They are the risk markers that are already in the guidelines mentioned here, class 2 indication, but they are also cardiac damage stage 2 or more, elevated BNP or troponin, and etc. And now, and I think I'm very optimistic on this aspect, and we've done some progress and we'll do more soon. I think the AI-based prediction tool will help us to enhance risk stratification and timing of intervention. Thank you so much for your attention.
Thank you very much, Philip, for this amazing overview. And I think this whole area continues to become more and more interesting. I think my colleagues have a few questions I will read out and maybe get your answers, and then I have a few questions we can discuss. First is they want to know about your energy loss index and how you use it in your clinical practice.
So the energy loss index is a way to correct the effective valve area that we calculate by the continuity equation for the size of the aorta, for the cross-sectional area of the aorta at the level of the sinotubular junction. Because if you have for a given valve airway, especially if the valve airway is in the moderate to severe, so not too severe, because if you have a very severe airway to start with, There is no pressure recovery. It's over. But if you have, the valve areas that we often have in these asymptomatic patients with severe AS, 0.91, 1.1, 1.2, and you have a small aorta, then you're going to get substantial pressure recovery. And so the patients may tolerate this AOA and this severe AOA for more time without any consequence. And so often by looking at the energy loss coefficient and energy loss index or divided by BSA, we often can reclassify patient from severe to moderate, because they have substantial pressure recovery, and this needs to be taken into account. So yeah, we look at this, especially when we are, as I said, we have an AOA that is between, 1.23 and zero point 0.9, zero point 0.8. This is where we calculate it. Otherwise, it's probably not relevant for, you know.
Great. And then my colleague Ashok Chaudhary is interested to get your response on how do you reconcile the fact there were no mortality benefit in the EVOLVE trial with CMR evidence of fibrosis, and do you think the BNP strain would have made a difference? And then he has a second comment, was the reason for hospital admission for early TAVR. Is it because they were called asking if they had any symptoms, or it because of really an unplanned admission by the patient? He feels like there is some difficulty in reconciling because so many patients were admitted within 1 year up for TAVR.
Yeah, I think, again, most of the readmission, if we focus on the clinical, I will start with this one first. As I mentioned, in the clinical surveillance arm of early TAVR, unplanned rehospitalization or readmission included the patients who actually were hospitalized for a conversion to AVR. So meaning, when the patients were randomized, yes, they had severe AS, yet they had no symptoms according to treadmill. But a few weeks, month later, they developed symptoms and or heart failure or whatever. And so they were hospitalized to get their IVR done. And as you saw, during the first year, 47% of the patients in clinical surveillance arm had converted to AVR. And of course, when you are converted to AVR, you are hospitalized before. And this was considered as unplanned AVR. I mean, this was a choice in the design. And I think, we've been criticized for this. I think this is fair. On the other hand, if we removed, this readmission because of conversion to AVR and only include, the readmission because of heart failure or things really more robust, let's say, in terms of cause of rehospitalization, still, it remains significant. And in the meta-analysis as well, and there are other benefits. So all in all, I think there is, yes, a benefit of intervening earlier, but this does not necessarily impact mortality, which was a bit expected still. Now, why, and I think it's a good question, why in EVOLVE we don't see, any benefit in mortality and just, and that the primary endpoint was missed. I think there are several reasons. I think, as I said, it was not really true early AVR in the early AVR arm. So if you include the patient in the clinical surveillance who converted to AVR relatively early, and the fact that the early AVR was not that early, finally, the two arms are not that different in terms of timing of intervention. Whereas in early TAVR, the difference was more substantial. And I mean, it seems to be a good idea initially that what they did in EVO to maybe select a high risk population. They enriched the population they included by adding some risk marker, elevated troponin, and evidence of myocardial fibrosis in the midwall that is more specific to AS. But maybe what we realize, maybe they shoot themselves in the foot. Because, well, first you wonder if you have elevated troponin, if you have myocardial fibrosis in the middle, are you really asymptomatic population, you know? And this is also a sign of patients who have more advanced cardiac damage. And as I showed, unfortunately, um, the cardiac damage is not really reversible. And so maybe the patients were already too advanced to benefit from the earlier intervention. Whereas in early TAVR, in general, by study design, the patients were less advanced in terms of cardiac damage, etc. And so they were able to benefit maybe more from the earlier intervention. By the way, we just getting, it's going to be, it has been presented and published simultaneously at the time of ACC by Brian Lidman. We did a sub-analysis of we had a blood biomarker biobank in early TAVR. And we looked at the results according to the BNP and troponin levels. And our hypothesis was that in the patients in the tertile of patients with elevated BNP or troponin we would find more benefit of early intervention. This was the initial hypothesis, but actually, no, not at all. Actually, there was even a trend for the opposite. Those with lower BNP troponin levels having more benefit of early intervention. So this comes to the fact that I think the earlier intervention is something that will give you and provide benefit to the patient if it's done, as soon as possible in the course of the disease, when you don't have too much, cardiac damage, advanced cardiac damage, and elevated biomarkers. Because then when you're more advanced, I think paradoxically, the timing of intervention may be less important.
So, Philip, that's very exciting and interesting, and in one of the papers that you and we worked on, and we are published in JACC Imaging, particularly at an early stage of aortic stenosis from sclerosis or early mild or moderate aortic stenosis. I just want to make a proposal, and I don't know if this hypothesis is true. I mean, let's assume. I think the primary assumption is that aortic stenosis leads to a lot of the damage, and maybe there is a substantial contribution of the overloaded ventricle. I mean, overload from the valve on the ventricle. But there is also a possibility that the same milieu with risk factors and the dysfunction, myocardial or other chamber dysfunction, is developing simultaneously while the aortic valve stenosis is progressing at the same time. And if that's the case, as you're pointing out, that the disease may be evolving together and may be impacted in some cases by the development of aortic stenosis. But if you take care of the aortic stenosis, it may continue to evolve because the damage, maybe there's some help. What I'm trying to tease out is as we see the epidemic of heart failure, preserved ejection fraction, and the valve disease, it is possible that in some of these patients, these diseases are coexisting in their milieu and very complicated in terms of what can lead to what. And in many of these patients, perhaps maybe we could see a benefit of general heart failure therapies like GLP-1 and all these other medications that are coming in. It may also modify the cardiac damage and may be equally useful. But my point to you is that the whole concept of that aortic stenosis leading to the damage may be true, but we do not know how many percent of people actually this relationship is strongly related and reversible, as you're pointing out, because your data is also suggesting that they may have a causal or they may be concomitant. Certainly, in our analysis, at least we were very surprised that some of the dysfunction was emerging earlier than the aortic valve stenosis was progressing. Your comments and your ideas, and I'm very excited to collaborate on with you on our ongoing work to see this epidemiology.
So, this is, I think, as you saw with Philippe Généreux, we often do the parallel with oncology. But this is where the parallel stops in the sense that, in oncology, the staging is necessarily related and linked to the primary tumor. It's the
Yeah,
metastasis come from the primary tumor, um, vast majority of the cases. But in aortic stenosis, the staging is not necessarily related to the aortic stenosis, and is more, as you said, concomitant or associated with. And by the way, as you shown in your work and others, we start seeing some cardiac damage and if advanced cardiac damage in patients with mild AS, with moderate AS, with no AS. Because they share, aortic sclerosis, because they, as you said, they share the same milieu of risk factors, and they are probably more the determinant of the cardiac damage, And I think we in previous work we showed that, for example, the concentric remodeling and the impaired LV longitudinal strain in the AS is more related to the metabolic milieu and the presence of metabolic syndrome, etc., rather than the AS severity per se. Having said that, it does not necessarily invalidate the concept and the clinical utility of the cardiac damage staging, because even if the advanced damage is not related in part or at all to the aortic stenosis, it remains that this damaged heart will be more vulnerable to the LV pressure overload and all the consequences associated with AS, and that the earlier intervention will be still beneficial. For example, let's imagine that the cardiac damage staging in a given patient with severe AS or even moderate AS, to be provocative, is not related to the AS at all, but is related to concomitant cardiac amyloidosis. Well, still, are you going to say, "Oh, I'm not going to do the AVR"? No, even more. You should consider the AVR and the early AVR even more, because this patient, because of the cardiac amyloidosis or because of the concomitant coronary artery disease or diabetes, is not able to tolerate this severe AS. So I think even if you consider that cardiac damage staging is not, there is no cause-effect relationship with the aortic stenosis, still it's a marker of poor prognosis and vulnerability of the patient
yeah,
to the AS, and so argument to consider earlier intervention. But I think it's also, and you're right on that, is that it's also, I think, an impetus for all of us to consider adjuvant therapy
yeah,
with GLP-1, with looking with treating looking for cardiac amyloidosis when there isn't, treating it, treating aggressively hypertension, diabetes
yes,
before intervention and after intervention. There has been a trial presented at ACC and published in New England Journal of Medicine showing that the glyphosine, post TAVI really reduce, the readmission for heart failure. So I think this is a new era that we have not yet touched much, but we
yes,
should
yes,
implement and not only think, well, aortic stenosis is something like all valvular disease that where pharmacotherapy
right,
has no role yet. That I think this is because we are thinking that the only pharmacotherapy that may be useful in AS or in valvular disease is the one that slow or block the progression of the valvular
yeah,
disease, of the grading of the AS severity, right?
correct,
But I think we have to think that what determines the prognosis is not the valve. I mean,
yes,
indirectly, yes, but it's the myocardium, is the cardiac damage. So if we
right,
can retard or enhance the recovery, the regression of cardiac damage after intervention by adjuvant pharmacotherapy, yes, for sure. I think this is the new trials we have to do. There are some ongoings, But this is where really I think there could be a very important role of pharmacotherapy, but not targeting the valve. This is maybe for the future, but targeting the myocardium.
Yeah, I think, Philip, that's one thing, very important message that I want the community to hear, particularly once you have a patient with cardiac damage and you're intervening either with surgery or TAVR, don't leave that patient, because the same patient afterwards will be equally susceptible to more issues. And I think if you don't keep a close eye on that, I think that will be a problem. And that's, people think it's going to be a TAVR is going to be a miracle and it will work and things will disappear. Maybe we need to prepare, and there's as a long journey with adjuvant therapy, connecting with heart failure and multidisciplinary team. I think we have a lot of work to be done in these people. Yes, we help them a little bit, but I think there is a lot of work that with pharmacotherapies that are needed for these people to continue their survival beyond their event of
Yeah.
the procedure.
I think if it would be the only take-home message of today, that would be the most important. Don't think that the AVR is the ultimate cure for the patient, and that's when the valve replacement is done.
Yes,
I will maybe see the patient in 5 years, as some guidelines recommend, to see if the prostate valve is functioning well. No, I mean, first we need good rehab, not neglect the rehab and start the rehab before intervention. And secondly, treat aggressively all the comorbid. Look for the comorbidities risk factor and treat them aggressively.
very aggressive.
And consider adjuvant therapy, targeting the myocardium as the evidence will come. I think this is
Right.
so important. I mean, the disease will still continue,
Yeah.
in the myocardium, and so I think, and we also need to protect the bioprosthetic valve because we have
Yeah.
seen and know that the disease may recur on the bioprosthetic valve. So
Yes.
when you're treating the cardiometabolic risk factor, you're also prolonging the durability of the bioprosthetic valve. So I think, really, I would say maybe the patients require even closer follow-up and management post-intervention than before.
Yeah, and a quick one, my colleague Dr. Maganti wants to ask you, aortic valve calcium score and the controversy. Has it panned out? Do we still use it, or we stop using it? I'm just throwing it out there for
Oh
sake.
yeah, that's a good question. So there has been this paper on which we wrote an editorial, and I think saying that, well, it's more for the patient with discordant grading, right?
Yeah,
And low gradient AS, that is a topic of interest for both of us and for many people for obvious reason because they are difficult. And the key issue here is you need to confirm that the stenosis is too severe to eventually refer the patient to intervention. And well, dobutamine Traseco is great for patients with low EF. But the
yeah,
vast majority of low gradient AS patients with discordant grading that we have are patients with preserved EF, paradoxical low flow. And for these patients, or normal flow low gradient, for these patients, dobutamine Traseco is not a good test. Even in those with low EF, we found, in the TOPAZ study, the multi-center registry, that 50% of them are still non-diagnostic at the end of the dobutamine stress echo. So I like dobutamine stress echo, but more and more its utility is limited. And the calcium score in the end is I think is a great tool. And that is not perfect as any, the sensitivity and specificity that we publish, actually, Marianne Clavel published, is around 80%. It's not 100%. So you're still going to have false negative and false positive. And you're still going to need to use your clinical judgment looking at the valve. Sometimes, partout, I'm sure, you
sure.
look at the valve
Yeah,
at echo and
sure.
eventually transesophageal echo, and you don't need the calcium score, right?
Yeah,
The calcium score is just to convince your cardiac surgeon colleague or your interventional
yeah,
cardiologist by giving them a number. But what if the number is just below or just above? Then you're in the gray zone, and but still, I think there is so much validation with the calcium score in terms of prognosis, diagnosis, meta-analysis, and well, there is this study, and there's many limitations that we highlighted in our editorials. The main problem is the gold standard they use. They use the valve area, the maximum valve area obtained at dobutamine stress echo. that we previously published was not valid to define true CVIS, So I think, the gold standard they used was wrong. That's the main reason why they obtained so poor results with calcium score. I think, and we published another study, well, led by Marianic, that kind of was a response to this previous study, just to confirm, the calcium score is useful. So still continue to use it. And I have to say that worldwide, I see a trend where people actually are using less and less dobutamine stress echo and more calcium score because they're often disappointed with dobutamine stress echo. First, because it is not applicable to patients with preserved EF or not much.
Yeah.
And second, because in those with reduced EF, 50% of the time it's non-diagnostic and you still have to do the calcium score.
Yeah.
And
Yeah.
it's more complex to do than, we are talking about calcium score is non-contrast CT, 15 minutes. It's longer to prepare the patient than doing the exam per se and the analysis. So no, to me, it's a no-brainer, very useful. But for some patient, not all. If you have a patient like we discussed today, calcium score is not really, it's not useful. It's really for those with discordant grading where you need to
Right.
confirm the stenosis severity.
And then a quick one, should we give them vitamin D supplementation if osteoporosis? What is the
So
controversy about that?
yeah, I think, so there are some studies showing that calcium supplementation may be bad for ectopic calcification. So ectopic calcification, including vascular and and valvular, of course. But if you combine calcium supplementation with vitamin D, then this is neutral or protective. So I would say, yeah, I think I don't see, even if we have to remember that some animal models of aortic stenosis was created with vitamin D, high dose of vitamin D, but I think the evidence, the epidemiology of evidence that we have, calcium supplementation alone appear to me not good, but calcium plus vitamin D is okay. And there's been, as you know, also trial with vitamin K
Yeah.
that actually have been negative. But
Yes.
the idea that was it would help to the carboxylation of the matrix GLA protein, which is protective against calcification, ectopic calcification in particular. But this has been, negative. The idea, the hypothesis was great, but the results were not. And same with all the anti-osteoporotic medication that have been tested, bisphosphonates and rank ligand inhibitors as well. All the treatment that we use to
Yeah.
prevent osteoporosis, where we were finding some hope. Actually, in the SALT-I2 trial, have been negative. So far, we have not any medication to slow the progression of AS, but we have the LPA lowering that is
Yes.
ongoing.
Yes.
We have also some evogliptin,
Yes.
and antaciquat. So there are at least 3, 4 trials that
That
are
are
on.
equally interesting to watch for. Thank you, Philip. I think for this extended time, really very, very kind of you, and very thank you to everyone for joining. We started a little late, but we really covered a lot of topics. This is exciting. It's ongoing. I think the LPA is something that is what is being discussed next week in a clinical trial that Harlan Krumholz is trying to bring to us
Oh, that's
for
great. Yeah,
outpatient.
that's very hot topic. And so,
Yes.
although again, I don't think this is the ultimate solution for aortic stenosis, but that's going to be the topic of
Yes,
another
this
grand run. And they
we'll
have
bring you back.
also the
Yes,
at-risk moderate AS. So we could
correct.
focus on the mild moderate AS next time.
Yes, we'll bring you back again next year, maybe in person, Philip. Thank you very much for the collaboration contributions, and we look forward to our deliberations in the near future as well. Thank you, everyone. Good night.
And I already accept your invitation in advance. Thank you,
Yes,
Pato.
thank
Good
you.
night,
Yeah,
everyone.
thank you. Take care. Bye-bye.
Bye.